Well, good evening. Yeah. So I think we've listened to enough as far as uh, ulcerative colitis is concerned, Profastanib, and of course now mesalamines and azathioprine. Dr. Ajit Sood, yes, please. In fact, I thought it should be an interactive. I will be also asking for comments from the floor. Welcome, of course, Sumit and Shobna Bhatia. Welcome. You've not been introduced. They're all stalwarts in the field of gastroenterology, and Shobna Bhatia, of course, needs no introduction at all. Sumit from Paras Hospitals, Gurgaon. No, Paras Hospitals, Gurgaon. Welcome. Well, moving on with this case, this lady, 54-year-old, with no significant past history, presents with a 3-month history of rectal bleeding, tenesmus, and constipation. 1 to 2 formed bowel movements daily with mucoid discharge and blood staining of stools, at times fresh bleeding too. Symptoms started after a brief febrile illness. No weight loss, has occasional nocturnal symptoms of urgency and occasional pain, lower abdomen, no other comorbidities. No systemic symptoms, no abdominal pain, no weight loss, no history of an NSAID use, and the labs are all normal. I'd first like to start off with Sumit. If you could just pick up the mic. Well, I think this is the very basic. Any other information that you would like to have? And at this stage, what are the various possibilities that you would like to consider?
So, as you have elucidated, this is a 3-month history, and it's a painless bloody diarrhea. So, ulcerative colitis is definitely high on the cards. But before that, I would also like to, in our country, rule out infections. So, a stool routine may be in place before asking for a flexible segment.
Well, I'll tell you, the stool routine shows plenty of RBCs, no parasites, nothing unusual.
I would like to straight away proceed with the sigmoidoscopy or a colonoscopy.
Okay. Ajit Sood, your opinion. 54-year-old onset of ulcerative colitis, how often do you see such a presentation? First onset of ulcerative colitis 3, and this history of febrile illness, is it significant?
Antibiotics or NSAIDs she must have consumed. No, sorry,
no NSAIDs, nothing.
Yeah. I think I will consider IBD as a possibility, though the age is a little odd, but IBD can occur at this age.
So what proportion of, out of 100 patients now, of what proportion of patients that you see in practice would be presenting beyond 50?
Beyond 50. If we talk of IBD in elderly, I mean, if I can start 65 or beyond that, it's around 10 to 15% patients, 10% or so who have onset after 65. 50, it's my guess, around, you can say 20-25% patients will safely be beyond 50.
Okay.
In India, as it is compared to West, the age is a little older. As with the passing time, we are getting more and more younger patients. But so far, if we look at our own database, I think 20-25% patients may be beyond 40 or 45 or 15, and maybe in the early 60s.
20-25%. A.S. Puri, you wanted to make a comment? I thought you also share the same.
For the benefit of the residents or the junior colleagues, in the Montreal classification, this would be A3 because she's beyond 40. Vast proportion of patients would usually come between 20 to 40. And A3, according to me, probably account not more than 10 to 15% of the patients. And there is a controversy whether these A3 onset has a milder disease or there is no difference. But what is well known already in IBD, that IBD can have a bimodal presentation. So this is the second peak that is coming, and since it is coming at the age of what, 50 odd, so we would say this is A3 disease.
A3 disease, and you said 10 to. So moving on, we did, like Sumit mentioned, we did go in for a scopy. And this is what we found. The rectum from anal verge up to 10 centimeters showed what you see on the left, and the remainder of the colon right up to the cecum showed what you see on the right. Now, my question to you, Dr. Shobna, is, of course, besides this interpretation, I would just like you to, I'd like to ask you two pointed questions. One, in a patient like this, do you always go in for a full-length colonoscopy? Now, what is it that you think of when you go in for a full-length colonoscopy, if at all you do? Number two, where all do you take biopsies from? Is it only involved areas or also uninvolved area? If you take it from uninvolved areas, which are the areas you take from?
So coming to the interpretation of this particular colonoscopy, what you see is that the activity, as you described, is mainly on the left side. And this is rectum up to 10 centimeters, which would mean really just the rectum and a very small part of the sigmoid, if at all. So this would be classified as proctosigmoiditis. And in this case, what you see is there is erythema. There seem to be, I don't know whether there is friability, because that you will have to tell.
There is friability.
And whether there was any spontaneous bleeding. What you see is there's a loss of light reflection, and therefore there is mucosal edema, as compared to the right, where the colon looks almost normal. Now, the question you ask is, which are the biopsies you're going to take? The biopsy from the particular area, definitely you would take. From the rest of the colon, yes, I would take a few biopsies, because though the endoscopic disease is only up to 10 centimeters, there is a very high chance that the next 5 or 10 centimeters are also involved. And if you take biopsies, you will find microscopic activity there. So sometimes that's important when you're deciding on what treatment to give. Once in a while, you might find a cecal patch, or rather a periappendicular patch, which is inflamed. Whether to take a biopsy from there is controversial, but mostly I do not take any biopsy from that particular point.
Ajit,
If the length is 10 centimeter, and if you look at the total length of the rectum, I mean, it can go up to 15 centimeters. So we can call it as proctitis more than proctosigmoiditis. So this is just a minor thing. The other point I want to make is, while doing sigmoid or colon in such patients where we suspect UC, if there is a sudden line of demarcation from abnormal to normal area, I mean, there's a sudden cutoff kind of a line, which happens in patients with ulcerative colitis. That's quite suggestive of ulcerative colitis. That doesn't happen in infective colitis.
Okay, so you're saying infected. Now, I'd like you to answer this question also. Do you share the same thing, that you take multiple biopsies? I say that in the interest of cost, also not to burden the pathologist more, you just take biopsy from maybe 10 centimeters above the so-called mark of delineation, and maybe one from the cecum. That's good enough. Should we take multiple biopsies from all over there? It's a practice in some centers. Before you, how many of you would actually go in for multiple biopsies from the uninvolved colon? You could raise your hands.
So it is
Not in
just
this
in the
patient.
next 5 centimeters, I said, not in the rest of the colon.
Okay.
Just 5 centimeters beyond whatever margin you see. 5 to 10 centimeters, because you're missing histological.
Any difference in
I think
opinion?
It's a straightforward ulcerative colitis. So we don't suspect CD here. So no point in having a multiple serial biopsies.
I would take one biopsy from just around the splenic flexure. So one from the involved area, and sometimes you can have histological activity, which here it doesn't look, but it's always in E1 disease, progression to E2 or E3 would occur over a period of 10 years, almost in 20%. So you have, if you think the patient is going to stick to you for that long, then it's always better to have that I've done him. And when he comes, say 2-3 years later, and if he has E3 disease, you know the disease has progressed from the rectum to the transverse colon, or in other words, it has become E1 has become E3.
Yes, Puri, you are an astrologer of sorts, I think. Well, okay, continuing with Shobna, what would you do as far as treatment or management is concerned?
So Right now, this is only proctitis. We'll wait for the biopsy report. Definitely, we can start mesalamine immediately because this is only proctitis. Mesalamine suppository also is enough. But if the patient is not responding, adding an oral may or may not be useful. Okay. Mesalamine enema is not going to work in this patient. So I'd just start mesalamine initially. If it is working, fine. If it doesn't work, then in that case, I might think of going for.
Well, the rest of the colon was normal, just 10 centimeters. How many of you would actually go in just for mesalamine suppositories alone? And how many of you would add an oral mesalamine to a mesalamine suppository? So you see, there is a mixed. What about you, Puri?
I would start both oral plus topical therapy. Topical therapy, as Shobna said, 5-ASA suppository. And oral therapy, I would.
You will. So I think you go, if I could just put a rough guess, it's about 30 or 40% who said a combination, 20% said no combination. What about you, Ajit?
Combination.
Combination. Two of them combination. Shobna, still you stick on to suppository. You would start and then watch. What about you, Sumit?
Combination.
Combination. So most people would actually prefer to go in for a combination. And if the patient responds well, then probably stop the oral and only suppository for a long term. Am I right?
I won't be stopping the oral also.
You
So
won't stop the oral ones also.
Die hard, still in the past tense, as I said, not into the future.
Okay. Okay. So we have a divided opinion. Any opinions from the house? Anything other than what we've discussed? Yes, please. Anyone? Please feel free. This is your session. I think the aim is to bring out some sort of an interaction. Okay. So as far as diet is concerned, what would be your advice, Sumit? Diet.
For this patient.
Yeah, for this patient.
So if the patient is having acute diarrhea, then in that case, I only restrict the lactose in their diet. And rest of the things, I ask them to continue.
I'm glad you brought this milk business out because there are a lot of people who actually say no milk. Do you still stick to no milk in these patients with ulcerative colitis? Ajit?
See, milk and milk products. Now, I ask patient that what is his symptomatology? Does he feel worse when he takes milk or not? But somebody, when he has active disease, I'll say, okay, you hold on milk for some time, but I don't say it's a lifelong restriction. But take plenty of curd or other, homemade cheese also is allowed in moderate amounts.
Okay.
And spicy food, plus, of course, the general instructions about, spicy food, or we ask patient whether there is any particular kind of stuff which he feels, aggravates his symptoms. And, but otherwise, the general kind of food that avoids red meat or this kind of food, this patient is not having very severe disease. So we don't need to put him on very, very strict restrictions like gluten restriction for some time. Some patients, we do recommend gluten also when they have very acute severe ulcerative colitis. Not we suspect celiac disease, but just, our presumption is that gluten may be a little difficult to tolerate in acute severe ulcerative colitis. But this patient has got mild to moderate disease. I will say, okay, general instructions.
So you brought up two things. One is gluten, second is milk and milk products. Third, fiber.
Okay, not major restrictions. I'll say that way. I will not say go for strict fiber restrictions.
Any opinion on fiber, milk and gluten?
No dietary restrictions. I would ask him, "Tum doodh peete ho? And do you tolerate it?" If he says yes, I said, go ahead. And if he says, I anyway don't drink milk, I said, then don't start it today. So I would, and even for fiber, for any other thing, most of, I would beg to differ from Ajit. I think all the gluten and everything has been absorbed in the small intestine. So there's nothing left that is, The only thing that I'd like to say for the younger faculty, for the younger people in the audience is E1 disease is really a nuisance value. So the patient will keep on having mild symptoms. So don't lose your patience. Patience, not patients, but don't lose your patience. That's very important. Go on going with them. Topical therapy is the answer. They'll keep on coming back to you. So this is one thing that they'll really draw you out. So I call it, it's a real nuisance value. So he keeps on having this little bit of blood in his stools, and he or she keeps on coming back. But I think you just stay, as we say, used to say I think in obstetrics, masterly inactivity. You just reassure them, sab theek ho jayega, and that's what.
Yeah, masterly inactivity is okay to a certain extent, but when this patient keeps coming back with increased frequency, Dr. Saab,
No,
kuch
then
nahi ho raha.
at some stage you will have to go on, and as I said, I think I showed in the slide, I would add a foam enema. So in this case, maybe a entofoam or hydrocortisone enema. The patient is still symptomatic, then I would add azathioprine. 3
Okay,
months later, the patient is still symptomatic, then possibly oral steroids.
possibly
Oral steroids, possibly.
oral
But if you
steroids.
have the option, if the patient can get, this is a right candidate for even pangraph enema if you have, which is not there in India. So tacrolimus enema is another topical therapy there. And the other thing that can possibly have a beneficial effect may be a MMX, the budesonide MMX, which again is not available in India.
You've been silent on TOFA. Would TOFA have any role at all, or is it that we have to convey? We need to convey a message. Can it be used? Should not be used?
My opinion, TOFA is a total no-no for E1 disease. I have seen several patients, they are non-responders. TOFA is very good for E3, okay for E2, and it's a non-starter for E1. That is my personal observation. Limited data, but that has what been. I get patients from Eastern UP, Bihar. They have been started on sometimes before salzopyrin, the first drug of choice. They've been started is TOFA. The E1 disease is a non-responder. This is my observation. I don't think it is not published data, and I don't swear by it, but as the numbers go and as we get more data, we will see whether this holds true or not.
Okay.
Just on one point, I want to clarify that E1 disease should not be interpreted as a mild disease. I mean, it can be very troublesome. And as Dr. Puri mentioned that with time, E1 can change into E2 or E3. So we have to take E1 as seriously as we take a patient with E3. Regarding the drug choice, it's that E1 disease, we put more emphasis on rectal therapy. But oral therapy, none of the drugs is selectively or preferentially more effective or less effective when it comes to E1. And TOFA, as such, we don't have a trial focused on proctitis results. But when we look at the data, there are patients with E1 disease who have been treated with TOFA. I am not averse to using TOFA in a patient with E1 if he has a severe disease. Severity and extent are not synonymous.
The reason why I brought up this TOFA, it was not there in the original script, but when Puri mentioned about azathioprine as one of the options, that's why I asked you, could TOFA be an option ahead of azathioprine if ever you're thinking of azathioprine?
I will go as per the protocol. If a patient is becoming steroid dependent or he's becoming steroid refractory, I'll start AZA first. And if he doesn't respond to AZA, then I will consider TOFA.
Okay.
We are both from Ludhiana, so we don't disagree with each other.
But I'm glad that he's also joined the astrologer bandwagon with you. I'll tell you in a little while why.
One more point I wanted to make was that progression of disease from E1 to E3 is seen in the younger age group. So if you have an A3, the chances of it progressing, the data is all there in the younger patients who have progressed. So I'm not sure about the,
If that depends on the duration of disease. With time, there are more chances.
Okay. Any comments from the floor? Basically, we are dealing with the management of an ulcerative proctitis patient. And we've talked about mesalamine, the topical preparations. We've talked about some of the oral preparations, our preferences. We've talked about diet. Any ideas? Okay. Now, this patient was diagnosed with ulcerative proctitis, as most of you would have guessed, started on mesalamine enema with complete response after 2 weeks. But I think where we went wrong was we had not counseled this patient properly. So what happened was when the patient was relieved and she found taking this enema very cumbersome, so she just stopped. She was happy. But 12 months later, 5 to 6 diarrheal bowel movements daily with visible blood in each bowel movement with nocturnal symptoms as well as tenesmus. So obviously here we have an incomplete induction therapy for ulcerative proctitis at diagnosis. Ajit, thank you very much for your, he has to catch a flight. So thank you so much. So now, Shobna, I think I should, no, or Sumit, sorry. Sumit, what do you think has happened and what would you do? In the same breath, I would like to ask you also that would this be a clinical situation that should raise a suspicion of something like C. diff or CMV also?
Okay, so very clearly she has had a relapse of symptoms.
You can speak loudly.
Yeah. So there is a clear relapse of symptoms here, and she has stopped her therapy. The induction was not complete, and she never went in for any kind of maintenance therapy. And now it's like, again, we are back to square one. So we'll have to start again from where we started again. We'll have to restage her disease. At this point, since the total duration has gone up, again, we have to look for any intercurrent infections which she has picked up. So C. diff, yes, but she has never been on any immunosuppressants. This is not, technically speaking, a steroid refractory disease. CMV, I'll not keep it very high on cards.
So your likely possibility here would be a relapse of the disease.
Yes, that's the first.
And you would not consider CMV as a strong possibility, but certainly C. diff. The patient has not been in the hospital, so you think the patient would
don't
have.
know whether she has been taking antibiotics on and off.
Okay.
Last time you gave us a history.
Okay. Is community acquired C. diff a major problem in our country?
It is not, but I don't think that we are screening enough also.
Okay. Any observations, any experiences with C. diff community acquired by anyone here in the audience? Yes.
yeah. So 2 points I'd like to make. First, in E1 disease, C. diff is distinctly uncommon. C. diff is more common when you have pancolitis. Second, as compared to non-IBD patients, in IBD, you can have community acquired C. diff. You don't have to have antibiotics. So that is the typical patient is 70 years old. She has a pneumonia. She has a CVA. She's lying in ICU. She's been subjected to all possible antibiotics and she comes with a watery diarrhea. That is C. diff. You go inside, you'll see bundi in the rectum. That's C. diff. In these patients who are IBD, they will come with a bloody diarrhea. So C. diff, yes, possible. CMV, Sumit has already clarified, it's a remote possibility. So unless the patient has been on steroids, I wouldn't. So what I would do in this patient would scope her again, just to find out whether there's been an extension in the last 1 year or so. And then,
precisely. That is why I said you're an astrologer. So what happened was a repeat flexible sigmoidoscopy showed a granular mucosa. Remember, yeah. Question.
Comment. This thing, especially in E1, I find many times that patients have a good response and they stop the medicines. And they again come for 12 to 24 months, they don't do. Sometimes I have also experienced that 1 or 2 of my patients, they took medicines for say 3-4 months and they completely all right. And they do not have symptoms, they sometimes come to me that now I do not have symptoms.
Kunal,
I
you
have
are
sugar.
asking a question or making a comment?
Making a comment.
What is the comment?
Comment is sometimes, is it that this, if the diagnosis is made by proctitis, it can be completely resolved and patient do not have symptoms? Sometimes that you say it's a nuisance, yes. Sometimes they completely resolve also.
You are saying that ulcerative colitis gets resolved on its own?
After some medicines for 3-4 months, they get resolved and patient doesn't have, but this is quite strange. That's why I'm
So-
putting this question.
So I'll
Sometimes-
tell you what happens. Basically, ulcerative colitis is a disease that has multiple
Usually
remissions and
proctitis, ma'am.
relapses, including proctitis. It's a disease of multiple remissions and relapses. So even when the patient is on maintenance therapy, the average number of relapses per year is 1 to 2, even on maintenance therapy. So we've got to be careful. We have to counsel the patient that ulcerative colitis is not just one-off colitis. This is similar to a disease like hypertension or diabetes and requires a lifelong therapy. This has to be counseled as soon as the patient comes. They get very disheartened when they come to know this, but if you tell them properly, otherwise they will come back like this with multiple relapses, and these relapses turn out to be more dangerous than the original disease.
Uh,
Apparently on sigmoidoscopy, colonoscopy, the mucosa appears normal. You do biopsy, still there is active inflammation happening there. So that is why, as Shobhana ji pointed out, there are no surface ulcerations, nothing visible. Patient doesn't have blood and mucus diarrhea, but again relapses
But if
because
they
the
are-
patient has not gone into deep remission.
But if they're asymptomatic, do we still treat them? With
I think
Exactly, yes.
we should have a maintenance therapy to continue on that.
That is why there is maintenance therapy
But,
exactly like
but,
other diseases.
I think.
I'm the devil's advocate.
I think, Dr. Bhatia, that
A
the.
patient who's asymptomatic, so who's
No, it's
asking?
okay.
Yeah.
So, as you know, there are three distinct subset of patients with ulcerative colitis. One could be just one episode and subsequently no more episode. And second one is relapsing remitting, as you already mentioned, most common. And third one is the chronic continuous one. So could, what Dr. Kunal was asking, could it be just one episode of ulcerative colitis and after treatment relieved and no further course?
So that is in less than 5% of patients. So if you have 95% of patients who have a remitting relapsing course or a chronic ulcerative colitis course, I think it is our duty to inform the patient that this is going to be a chronic disease.
So I think where we went wrong was the counseling, but I think the point that Kunal was mentioning is in an asymptomatic, there are many patients who are asymptomatic. Now, would you insist that they take these so-called suppositories every day?
They are not asymptomatic. They are in remission.
They're in remission. Okay. So if they're remission, that period could go on for some time. So do you insist that they should take it in the same frequency, or do you really climb down on the frequency and say once or say twice a week or something like that?
No, the dose has to be.
Has to be once. Okay, fine.
I think
One point.
So,
One
so
point.
there are
Yes, sir.
studies which suggest, just a minute, there are studies which suggest, so you can continue speaking, that the induction dose is actually similar to the maintenance dose.
Okay. No. I was communicating because I want to know how much time I have. That's all.
So you had a question, yeah. Yes.
Yeah, you say this patient initially had an episode of diarrhea which was diagnosed as UC, and the patient went into remission after treatment. Now, second episode is happening after a gap of 12 months. Now, it could be as well as simple infective diarrhea. Why not? The first step should be, instead of doing a sigmoidoscopy, a stool examination and stool culture will be first step to do, and then go ahead for colonoscopy. Although
So,
you keep in mind that the patient could be having a relapse. So I
okay.
think the common thing should be thought of first.
So that's why I did mention stool examination was done, a lot of RBCs, nothing
I'll
else.
answer that question. There's only one paper from the AIMS group. They showed that there was a small percentage of patients who had parasitic infections, but they included Giardia and everything also. In general, in my experience, when a patient with ulcerative colitis, even when he or she has been in a remission, comes back the chances of you finding something like EH is very, very remote. Invariably, it is a relapse of the disease.
Coli, it could be Shigella, it could be
Yes,
anything,
but
anything.
Shigella, sir, in general, it's a disease of less than 5 years. It's preschool children, that is the peak age for Shigella. Very rarely would you have an adult. You can have things like EHEC or other organisms which can cause, but Shigella essentially is a disease of less than 5 years, preschool children, poor socioeconomic status.
And would you also
that-
care to comment on the distribution of lesions in Shigella?
So Shigella, if you have Shigella, then it's very similar appearance to ulcerative colitis because it's a diffuse involvement. Whereas in EH, you'll get very discrete lesions with normal intervening mucosa, clustering of lesions, the poached egg appearance. So just a look at the colonoscope will tell you that this is amoeba. You don't have to even do a biopsy, I think. Of course, you would do it, but it's so typical appearance that you can start the treatment and you're going to be right almost 99 times out of 100.
Well, Dr. Puri, just a
Job,
minute. A bit of difference of opinion. Definitely infective colitis you have to keep in mind. Regarding your comment regarding bacillary dysentery, don't forget the first World War, Battle of Gallipoli was lost because of a severe epidemic of bacillary dysentery there. Remember?
Okay.
That happens every.
Okay, I'll have to move on.
GN, unless you are coming on the fecal,
Bankaji, tell me.
unless you're coming on the future of the fecal cal, Dr. Puri, don't you think, I think we should have surveillance of fecal cal protected in these patients as a marker for activity of the disease coming in rather than rushing for the sigmoidoscopy or colonoscopy? I think that will be more.
fecal cal protection
Let me get an opinion from the floor. How many of you in a patient like this would go in for a fecal calprotectin to find out if there's a continuing activity or relapse? How many of you?
In this patient where blood is obviously there, I would not.
But suppose now patient has gone to remission. Do you actually do frequent calprotectin?
Yes.
levels?
Now the reason we have now a very clear-cut subset of a classical entity which is given a separate name, the so-called irritable inflammatory bowel disease, also known as irritable inflammatory bowel syndrome. That is an overlap of IBD and IBS. Almost 40 to 50% patient of ulcerative colitis, almost 50% patient of Crohn's disease. Once they go into remission, still continue to have some features which fit into category of irritable bowel syndrome.
Okay.
That shows that there's one of the mechanisms described for IBS that low-grade mucosal inflammation probably is there. Probably in those situations, definitely, where we have to find out whether the patient is going for a relapse of IBD or he's just doing IBS, fecal calprotectin is required.
Okay, thank you.
My only question is,
Ah.
what has been nagging me is what level of fecal calprotectin you should take as a cutoff. People have mentioned anything more than 40 is abnormal. Some would say something else. So in clinical practice, what cutoff should we take for fecal calprotectin to say that, well, this suggests a relapse of IBD and this is IBS?
Do we have any answer to that? What is the level of fecal calprotectin that you take, cutoff?
So, the amount of fecal calprotectin lost in the stool is a function of the extent of the disease. So any patient who has E3 disease is going to have much higher values versus somebody who has E2 disease versus somebody who has E1 disease. There is a paper from AIMS where they've given a cutoff value. That cutoff value was, I think, somewhere between 400 or 500. And they said, in fact, they went ahead and said that if you have a value above this on day 3,
that is
day
1,000.
3 or day 4, that is
AIMS, that is 1,000.
Yeah.
In the AIMS.
So on day 3, the patient will, high proportion of patients would end up with colectomy. Unfortunately, I don't think I follow that. And because in that case, most of my patients will be ending up with colectomy. Okay,
the last issue, I will be winding up. So this is a report of the flexible sigmoidoscopy, and you find, like A.S. Puri had mentioned, and that's why I said astrologers, granular mucosa with absent vascular pattern and contact friability from the rectum up to beyond the splenic flexure. So Shobna, what has happened and how often do you see this sort of a thing? Because we were always taught once a proctitis, always a proctitis, once a left-sided colitis, always a left-sided colitis. So how often do you see this thing happening?
So over a period of time, 20 to 30% of patients will have a proximal extension. Older textbooks mentioned that up to between 10 and 15 years, it takes to develop an extension, and patients go grade by, I mean, the extent goes up by about 15 to 20 centimeters. So that is what happens. Doesn't happen over a period of 1 year from what I know. And in a period of 1 year, that's too rapid if there has been an extension.
So, is there any way, or is there a subset of patients who actually tend to have a more aggressive disease? And if so, how do we detect them? Because this is a patient who came with just an ulcerative proctitis, nothing else.
So quite often it is the younger people. I mean, if the disease starts in pediatrics or at the teenage group, and those who have PSC, those are the ones who tend to have more extension, who develop extension of the disease. But in others, it is less common. That doesn't mean it is not so.
Okay, so basically the message is this was with the further the other case aspects will be dealt with in the subsequent case capsule, because they are dealing with severe colitis and all those things. So I think I'll leave it to them. C. diff and CMV is also going to be covered up. We did not want to have an overlap. This is basically the basics, very basics. And I think a few important messages that do come out here is, of course, ulcerative proctitis can be a big pain, literally, and it can be a source of severe stress to the patient as well as the treating doctor. Mesalamine suppositories and enemas are probably the best way to go ahead. Most people thought that you should add a mesalamine oral preparation in addition to topical preparations. Number 3, the investigation should also include a stool examination, a stool culture, okay? But there is an opinion, it's a divided opinion. But these patients actually should be counseled very properly about the fact that the disease is going to be a long, drawn-out battle. 4th, some of these patients could have a proximal extension of the disease in due course of time. So it is not as simple as it seems. And this is what happened to the patient. This patient finally had a very aggressive disease, in fact, ended up requiring infliximab, and that is how she actually settled down. But that is a different story for another day. Thank you very much to all the panelists, Sumit, Shobna, and A.S. Puri, and of course, Ajit Sood in absentia. And thank you, Rupa, for this opportunity.
Thank you, Dr. Ramesh. As usual, an excellent case, and I think it was a very good discussion. As I said, there are many who are having evening flights. So in the interest of time, the tea, coffee, and snacks will be served inside, and we can continue on the same lines for the program. For the next talk, I'd like to invite our chairpersons for the session. Is Dr. Chaubal here? So Dr. Chaubal is going to chair this talk, and Dr. Setu Babu. I think, can I ask Dr. Banka to please come up? I can't find Dr. Setu Babu. If you could please chair this session with Dr. Chaubal. So the talk is a very important one. Positioning biologics in the management of ulcerative colitis. When should we use it? What should we do? You can grab a coffee and come in, as well as coffee and snacks will be served inside as well. So Dr. Uday Vishal unfortunately could not make it for some unavoidable reasons, and we have him online and he's waiting. And can we have him on the screen, please? Dr. Uday needs no definition nor description. He's one of the leading IBD stalwarts in the country. Over to you, Uday. Are you online?
Yeah, I'm online. Can you hear me?
Can you switch on the camera, please?
Can you hear me? Yeah, my camera is switched on. I can see myself. Can you see me? Hello?
Uday, can you hear us?
Yeah, I can hear you. Can you hear me? Can you hear me?
Hello.
Can you hear me?
Yeah, hi, sir.
Yes, thank you. So thanks, Dr. Rupa and AIG for inviting me. I'm sorry that I could not come. I would love to come. I was listening to all of you and I was rather quite interested to meet friends physically. Now I'll be talking about positioning of biologics and small molecule in management of ulcerative colitis. Let me tell you, I was listening to some of the speakers earlier, such as Dr. Ajit Sood. Now, what they were saying is ulcerative colitis cannot be really cured. It is a lifetime disease like diabetes or hypertension. So what are you trying to achieve by treating this patient? What we are trying to achieve is we are trying to induce remission. We are trying to maintain remission. In the recent time, we have realized that the definition earlier was inducing the remission and maintaining the remission are not enough. Like in diabetes, you don't want the patient to be just asymptomatic, but you want them to have good HbA1c. Similarly, in ulcerative colitis, you want endoscopic healing or even histological healing. If you get endoscopic healing and histological healing, it is really a perfect control. We want a good quality of life of this patient. We want to prevent complication. We do not want them to use steroid. We want to maintain adequate nutrition and growth and avoid hospitalization. So practically speaking, we are not curing them, but we are trying to achieve this by our treatment. But if you look at what all treatment happen over the course of time, this will be very useful to see how we can place the different treatment in this patient. The first clinical trial of cortisone came in 1955. And we all know that was a landmark discovery which showed that corticosteroid intravenous can do wonder in this patient. Subsequently, the head-to-head trial of sulfasalazine, azathioprine and placebo came in 1979. It was in Crohn's patient. First clinical TNF came in 2002. First head-to-head trial of infliximab, azathioprine versus infliximab plus azathioprine came in 2010. 2013 was the first clinical trial of anti-adhesion molecule. 2016, first clinical trial of anti-IL-12, IL-23 like ustekinumab came. First clinical trial was a biosimilar came in 2017. 2018 came the first small molecule that is JAK inhibitor. And 2019, we have combination of biological. Now we know that ultimately the sulfasalazine is a good drug or 5-ASA is a good drug and corticosteroid is a good drug. So does it mean all this development that happened over the years are useless? Obviously, no. Look at this. All this drug has their own position. Like what happens is if you have a very mild disease, left-sided disease, as I was hearing, you give just topical 5-ASA or maybe systemic 5-ASA. Oral corticosteroid come in little more severe disease. In acute severe colitis without toxic megacolon and perforation, you actually give IV corticosteroid. But if somebody has toxic megacolon, has perforation, most of the time they land up in surgery. Now, question is, if we treat somebody with IV corticosteroid, does everybody recover? If we treat this patient subsequently only with 5-ASA, does it work in 100% patient? Obviously, no. I'll show you data on that. So therefore, in this sort of situation, you need rescue therapies so that you do not want colectomy, or you want rescue therapy to maintain their remission. Now look at these landmark studies. Induction of remission, if you give IV corticosteroid, 85% patient would recover. But what will happen is that 15% would not recover. And these 15% straight would have gone to colectomy once upon a time. But now we learned, I'll show you that study, which showed cyclosporine works in this patient of almost 80%. So that means 15% patient who did not respond to corticosteroid, 80% cyclosporine will work. But if you control them with cyclosporine, subsequently you give them only 5-ASA, almost 70% will require colectomy in next 6 months. That means these are the patients where 5-ASA will not work and maintain remission. How to maintain remission? We all know 5-ASA works in 75% patient, but 25% becomes steroid dependent, meaning thereby when you are tapering the steroid or stop the steroid, within 1 month they will have relapse. And this patient, again, you need rescue therapies such as azathioprine and biological. Here is the cyclosporine study, very interesting study, published in NEJM, but with only 20 patients. Hardly ever you see such study in NEJM, where 20 patients were randomized to cyclosporine or placebo, and you can see most responded to cyclosporine. And those who were in placebo, when they are crossed over, they responded again to cyclosporine. So looking at these, can we now ask ourselves a question? Does all these drugs that we are talking about, do all these drugs that we are talking about, they have position in management of ulcerative colitis? Now I have made this chart. Now this is acute severe ulcerative colitis not responding to glucocorticoids. You have several rescue therapies such as infliximab, adalimumab, vedolizumab, cyclosporine and tacrolimus, surgery, and tofacitinib. As I go along, I will show you that how useful or how useless some of these drugs are. On the other hand, acute severe ulcerative colitis, you have to maintain remission. Again, it can be done with infliximab, adalimumab, vedolizumab, azathioprine or 6-mercaptopurine, methotrexate, tofacitinib, surgery, and so on. Now let us look at the pathogenesis of ulcerative colitis and the treatment target. We all know inflammatory bowel disease is a condition where the normal microbiota or abnormal microbiota triggers an abnormally exaggerated immune response. And for exaggeration of immune response, you need the marginalization of the immune cells. The marginalization happens with adhesion molecule. And now what happens is you have the blocker for adhesion molecule, such as vedolizumab or natalizumab. Now these immune cells lead to production of TNF, and we have blocker for TNF, such as infliximab, adalimumab, certolizumab, and golimumab. Now also there are several other cytokines such as IL-17, IL-23, IL-12, which are pro-inflammatory, and they can be also modulated to treat ulcerative colitis patient. And you have anti-inflammatory cytokine such as IL-10, and you can modulate that also. Now, what are the biological? There are several biological. The approved one are infliximab, adalimumab, certolizumab, pegol, and golimumab. Also, now vedolizumab is approved. You have ustekinumab now, which is anti-IL-12, 23, and tofacitinib, which is making a lot of discussion today. And in fact, I heard some of the discussion from the earlier speaker. Now, infliximab is superior to adalimumab in ulcerative colitis. What is adalimumab? People thought adalimumab, because it is not typically a chimeric monoclonal antibody, it is more humanized antibody, it will be better than infliximab, because infliximab, we all know, that is a chimeric antibody where 25% is non-human and the 75% is human. But what happens is in adalimumab, most of it, except 5%, is human. So people thought adalimumab will be better. But this is a surprise to most of the investigators, including ourselves. When we did a study, and this is 70 patients from 4 centers, and what in that study we found, interestingly, where we are talking about ulcerative colitis, adalimumab is inferior to infliximab. And these are obviously biosimilars. These are not the originator molecule. On the other hand, if you look at Crohn's disease patient, adalimumab is as good as infliximab. So not only this study, there are several other studies which suggest adalimumab is good, not good for ulcerative colitis, but is good for Crohn's disease. So if I'm treating a patient of ulcerative colitis with biological, my choice would not be adalimumab, but infliximab. Now, what are the anti-tumor necrosis factor alpha antibody? I have already told this, so therefore I'll skip this. Now let us come to one of the major molecule, that is the orally active biological, which is a small molecule. But before I go to that, let me talk about the immune cells, how it works. You can see this one is the immune cells. And the immune cells are regulated by IL-10 or interleukin-10. Interleukin-10 is a regulatory cytokine. So what it does is it keeps the immune cell controlled so that the immune cell does not malfunction, does not lead to self-destruction. So that's why the T regulatory response, which is mediated by IL-10, is very, very important to keep our system in check or the balance. Now, this IL-10 in the immune cell works through IL-10 receptor. And this IL-10 receptor works through genus kinase, as you can see here. And genus kinase leads to phosphorylation of STAT3. And this STAT3 phosphorylation within the cell actually lead to transcription of the protein such as TNF-alpha, IL-6, and IL-10. So therefore, all the inflammatory cytokine that we are talking about, they are produced, the final common pathways here. So they are produced because of IL-10 either overacting so that there is a less production of anti-inflammatory cytokine, pro-inflammatory cytokine, such as TNF-alpha, IL-6, and IL-10, or if IL-10 is underactive, then there will be more of the production of this cytokine. So just look at this mechanism, and you can recall about 3 decades ago, we are talking about H2 receptor antagonist, and the H2 receptor antagonist was reducing gastric acid secretion through histamine, which used to stimulate the parietal cell like this. But also there were other mechanisms to stimulate the parietal cell, such as acetylcholine or gastrin. Now, what we realized is if we block the final common pathway, that is proton pump, it worked better. Is it possible that in case of when we are talking about the tofacitinib or the small molecule, because they are working possibly in the more in the final common pathway side, it would be better? maybe, but only time will prove that. Now, this is a tofacitinib study in biologic experienced acute severe ulcerative colitis. What does it mean? These are the patients who had ulcerative colitis. They were treated with biologic. They failed biologic therapy and they were randomized to tofacitinib and no tofacitinib. And you can see here, tofacitinib worked better there than the anti-TNF because anti-TNF failed and tofacitinib worked. This is another study from William Sanborn group from Mayo, which showed the efficacy and safety of tofacitinib in ulcerative colitis with or without prior anti-TNF. And you can see there, those who are TNF failure, anti-TNF failure, there the response rate was lesser to the tune of 58%. But when we talk about the patient who were TNF naive, the response rate was higher. So that means the tofacitinib works even in the TNF failed, anti-TNF failed patient, but when there is no TNF failure, it works better. Now, these are two important studies. This is Octave study induction and Octave study induction 2. And you can see remission at week 8, 18% versus 8%, 16% versus 3.6%. Obviously, you'll say these percentages are very low, but let me tell you, these percentages are low because many of these patients are very selected patients who did not respond to the other drug. 31% achieve mucosal healing compared to 15% in the control. And you can see here, those who had TNF, anti-TNF treatment failure patient, their response rate was 24% compared to 40% where the TNF was not tried earlier. Now, infections was a complication, 23% in tofacitinib treated patient compared to 15% in placebo group. Now, what are the adverse effects of tofacitinib? Obviously, it is not free from adverse effect, and much you have learned actually from studies in immunological conditions such as rheumatoid arthritis, because their experience is more. So this group of drug has neutropenia as a side effect, which is a class effect, lymphopenia, hemoglobin reduction, lipid changes. So you can develop dyslipidemia because of tofacitinib therapy, LFT changes. So therefore, if somebody on tofacitinib, please do LFT monitoring. Also monitor the creatinine. There's a decreased fertility in male and female, possible teratogenicity, deep venous thrombosis and pulmonary thromboembolism, and herpes zoster. Also in the pregnancy, it should not be given because it crosses the placenta and it is a group D drug. So do not forget that a fellow in whom you are going to start tofacitinib, he can develop activation of herpes zoster. How commonly does it happen? This is one of our patients where we started tofacitinib, and a few days later, she had this. You can recognize these are herpes. Obviously, Chang smear was positive, and we had to discontinue tofacitinib in this patient and treated her with vedolizumab, and she's doing well on vedolizumab. Almost 10% patients who are treated with tofacitinib can have herpes zoster activation. Now, question is, you will say that CMV is a same type of virus or same class of virus. What tofacitinib will do to CMV, we don't know, but we know CMV is an important problem in IBD patients, so we are waiting for the literature on this. So let me now look at management of acute severe ulcerative colitis. Where do I position the biologicals and the small molecule? Here is my slide from the introspection or from my experience. Infliximab is yes. But when we are talking about infliximab, let me tell you, we are talking about both infliximab originator and biosimilar. Most of the infliximab that you are getting today are biosimilar, and there are studies to show that infliximab originator is as good as biosimilar. Adalimumab, I'll give a cross. You know why? Because adalimumab doesn't work so well in ulcerative colitis. In acute severe ulcerative colitis, I will give a cross for vedolizumab as well, because vedolizumab has an advantage. This one is more gut-specific immunosuppression or immunomodulator. Therefore, TV activation has been found to be less with vedolizumab. But vedolizumab is a very slowly acting drug, and therefore I would not say that vedolizumab will be a good choice for acute severe ulcerative colitis, but you can maintain with this drug. Cyclosporine, yes, it is a good drug. Surgery is a time-tested method, and tofacitinib large dose, such as 10 milligram thrice daily, may work in acute severe ulcerative colitis. Now, maintaining remission, you can use infliximab, but not adalimumab. You can use surgery is there. Card, and these have been discussed by my previous speaker, and tofacitinib is also in the card. Now, also I've put here the cost data. When you talk about infliximab, the cost is high. Vedolizumab cost is high. Even cyclosporine cost is high. As you go down to tofacitinib, cost is lower. Similarly, when you talk about maintenance, if you look at infliximab, vedolizumab, surgery, the cost is quite high. On the other, when you talk about azathioprine, 6-mercaptopurine, or tofacitinib, cost is low. So azathioprine has a good place in the treatment of maintenance of remission in this patient, but in azathioprine intolerant patient, you can try tofacitinib because azathioprine may cause cytopenia in some patient, azathioprine may result in pancreatitis in some patient, and in this situation, you can take tofacitinib as a choice. And obviously there, where azathioprine doesn't work, now there you give tofacitinib. So thank you so much.
Me and Dr. Chawla, me and Dr. Bankar sharing the session.
Yeah, hello sir, can you hear us?
I think
yes,
we can get some questions from the audience.
No.
You can ask me, and I can transmit it.
Sir, can you hear us?
Yes, we can hear it. I can hear it.
Uday, this is Dr. Mohan Prasad, sir. Can you hear me?
No, he can't hear me.
I can hear you. I can hear you. Can you hear me? Yes.
Yeah, question will be transmitted to you by Chaubal. Mohan
Okay.
is asking the question.
GC. Hi. Yeah. My question is, in severe acute ulcerative colitis, he is, given the role for tofacitinib, but none of the guidelines have ever recommended. And there is only one trial, I think, which showed some benefit. So are we justified at this point of time to include tofacitinib in severe acute ulcerative colitis?
Dr. Ghoshal, can you hear me?
Yes, let me answer. I've listened to his question. So some of these I have given from the introspection, not exactly from the trial. As time will go, we'll learn more about tofacitinib. But what I'm saying is the gold standard methods are biological, such as infliximab, cyclosporine, surgery, and corticosteroid IV. These are the 4 gold standard methods. But what we do is that both our group as well as AIMS group, what we have done is that when a patient, you have tried corticosteroid, is not working. There are too many comorbidities and surgeons do not want to take up for surgery. We have given high dose tofacitinib, such as 10 milligram thrice daily. Obviously, we are not talking about a patient who has very fulminant ulcerative colitis. We are talking about a moderately severe to severe ulcerative colitis, according to True Law. And it worked, but we need more experience on this. And this is particularly those patients where your surgeon put his hands up and the other drugs have failed, such as infliximab or corticosteroid.
Well, Uday, Chobale, can you hear me?
Yes, I can hear you.
See, it's a very simple question. See, all biologics, when we start, we have to screen this patient for any latent infection like tuberculosis, etc. Supposing that you have a patient who has a latent tuberculosis diagnosed. Now, these patients are also sick where you are going to start biologics, especially in India, you really wait for a long time before starting biologics. We don't have a time actually to treat that latent tuberculosis initially and subsequently to start. So what I'm trying to say, do you start anti-tuberculosis along with biologics, or still you treat them initially for some time with this and then subsequently start biologics?
Yeah,
What is
very
it?
good, very good question. What happens is all patients in whom we have to give biology, what we do is that we'll look for tuberculosis. So typically we'll do 1, 2, we'll do one of the quantiferon TB, gold or IGRA, we'll do a HRCT. And if these are positive, we'll avoid biologic if we can, if we can. If we can't, actually there, we give ATT plus biologic. Because if surgeon takes this patient, I would say, please go ahead. I don't give biologic in this patient. But our surgeons are very conservative. Most of the time we'll end up giving them biologic plus ATT. Remember one thing, if you are also giving tofacitinib, you should work up for tuberculosis. Second is ideally even azathioprine, you should work up for latent tuberculosis. And in fact, recently there was a paper submitted from US on a large number of patients where they showed that inappropriately people with azathioprine therapy, they had poor workup for tuberculosis before starting compared to biologic. So because biologic is an expensive drug, more new drug, we tend to do as per protocol. And when it comes to azathioprine, because it is an old drug and we think you are too familiar with it, we do not do workup the way you should be doing.
Last question.
Last question, please.
Sir, my name is Shailendra Jain. I want to ask a question and comment also.
Yeah.
When we know that there is a with the tofacitinib, there is a chance of VT and cardiac risk factor and also dyslipidemia. Just like endocrinologist, when they have high risk, they start the aspirin and the statin. Why not with the tofacitinib?
Yeah, very good question. Very good question. See, I have showed you in the adverse effect panel that one of the complication is DVT and pulmonary thromboembolism. And there are studies on rheumatoid arthritis patient. Actually, sometimes the pulmonary thromboembolism is fatal. So you have to be very careful if somebody has a risk of all this pulmonary thromboembolism and DVT. I think better not to start tofacitinib. That is one. Now, there is no literature on this. Only problem is that from the simple introspection, I can tell you, NSAID precipitate attack of ulcerative colitis and Crohn's disease. You know, one of the way why NSAID precipitate attack of ulcerative colitis is because prostacyclin is a protective agent for the colonic mucosa. And when you give non-selective NSAIDs such as aspirin, it blocks prostacyclin pathway as well, and it leads to relapse of ulcerative colitis and Crohn's disease. Therefore, I would say do not start aspirin or similar drug in patient of IBD. And to the best of my knowledge, there is no randomized control trial where one group are given tofacitinib plus aspirin, other group are given tofacitinib alone, and probably no such randomized control trial would be done. So I will not start aspirin, yes.
Uday, we are terribly disappointed that you are still maintaining online lectures with you. We would have loved to have physically present here with us. We enjoyed your talk so much. Thank you very much. You are a rock star.
I like to meet all of you. I like to meet all of you. Okay, maybe in future we'll meet sometime if this continues, corona pandemic remains under control. Thank you so much.
Thank you.
Thank Rupa for the great opportunity, and thank my chairperson.
Yeah, thank you, chairpersons, and I'd request Rupa to hand you over your mementos. Uday, your memento will come by hand to Lucknow shortly.
Yeah, very good. Thank you.
Online only, okay. Please, you can go. Dr. Chaubal and Dr. Banka. Thank you.
Thank you.
Well, we move on to the next session. A live case for discussion is always interesting. Today we have Dr. Ajay Kumar, whom really needs no introduction, one of the senior most and well-known gastroenterologists in our country. He is going to be the moderator and discuss a case of acute severe ulcerative colitis. And with him on the panel are Dr. Chetan Bhatt and Dr. VG Mohan Prasad, two senior gastroenterologists. Chetan, as you know, is from Mumbai, and VGM is from Coimbatore. Both need no introduction. But joining them will be two of the younger generation, Anurag Jaina from PGI and Dr. Partha Pal from AIG Hyderabad. So we'll have a combination of experience and youth who will take up the questions from Ajay. Ajay, over to you. Thank you.
Thanks, Manu and Rupa. A wonderful meeting, enjoying since afternoon today. And after a long, long time, it's really, yes, long, long time. It's good to be back for the physical meeting old friends, sharing jokes and exchanging experiences over the last 2 years. Well, friends, it's been really a great meeting. You have been hearing lots about ulcerative colitis today. A lot of experts talking about different case scenarios, recent advances, and so on. I believe almost everybody here is a gastroenterologist, or we have non-gastroenterologists also. Are there any non-gastroenterologists here? Physicians, surgeons are there? Okay, good. So I will taking a practical approach, which all of us will face from day to day, asking practical questions from these experts. I'm not the expert, I'm only asking questions to them on your behalf. And in between, if you have any clarification, please do not hesitate to ask. Earlier, Dr. Usha Datta and Dr. Vishal Sharma used to be there. I did not get time to change my slides, but we have two bright young gastroenterologists, Dr. Jaina and Dr. Partha. So they will do justice to that. State-based, starting from case, 30 years male, 3 weeks history, bloody diarrhea, more than 6 per day, anorexic, tachycardia of about 100 per minute, afebrile, no extraintestinal manifestations, anemic, high ESR, low albumin, stool shows pus cells, RBCs, but no ova or cyst. Culture does not show any salmonella or shigella. Patient has been given both antiamoebic, quinoline plus antiamoebic for about 5 days and shown only a limited response, hardly any response. Let me start from you, Dr. Jaina. Do you need any more information at this stage in this particular patient? Or oh yes, please carry on.
Sir, it's a difficult case to start with because very short history of 3 weeks.
Can you take your mic close to mic?
Sir, it was a short history of 3 weeks.
Yes.
Then
no significant past history.
No significant past history. Patient had partial symptoms, partial response to antibiotics and
almost negligible. You say.
Sir, I would like to know the sigmoidoscopy.
Okay. So basically, what is the question in your mind? What are you thinking as? I mean, what is your diagnosis at this stage? Let me put it like this, straightforward. Can you read
it could
the question?
Be the first episode
is
of.
Is it a first episode of ulcerative colitis, or is it a acute self-limiting colitis? On context of that, you will like to have a sigmoidoscopy picture. Well, anybody like to offer anything else? Please feel free. It's a free for all. Just raise your hand and shoot.
Ajay, can you go back on that slide?
Yes.
I just wanted to know why you put this acute self-limiting colitis here.
Basically,
because see, the patient is sick, tachycardic, anemic, and has got more than 6 bloody
This
stools.
question I'm asking you, you can't ask any questions to me.
No, I was wondering
no,
why
I have
that
asked you,
found a
is it,
place on this
what
slide.
is this? You said, no, it's okay. I agree with you. I am nobody to differ from you. Huh? Okay, so let's go ahead.
So acute self-limiting colitis by definition resolves in less than 4 weeks. Correct me if I'm wrong. And infectious etiology is often suspected, but stool cultures are positive in about 55%. And common causes we are all aware of, these I've just put. The challenge for a resident or a clinician in the initial phases in a situation like that, how do you differentiate? If you look at this, there's no hard and fast differentiation. There are all relative features. And I've tried to put that in the slide here, that the patients of acute self-limiting colitis have an acute onset. Usually the diarrhea number is more, and they may have fever. This patient did not have fever. This patient had almost 6 stools per day. But as I said, these are not absolute figures. These are all one by one. You need to look at that. A patient did not have fever and the onset was insidious. And when you look at the labs, you can just tell me one lab which will help us, Jenna. Which one lab parameter which will rely more? Just to highlight that. I put it here actually. Huh? Thrombocytosis, do you think it's important?
So thrombocytosis is a marker of inflammation in ulcerative colitis.
Right. So lab also may be similar. Of course, I mean, I have seen that fecal blood, anemia, these are all common things. But stool cultures may or may not help if you find positive. Thrombocytosis. A platelet count of more than 4.5 lakh is seen in almost 70% patients of ulcerative colitis, and only 1.6% of acute self-limiting colitis. This is one message that I want while differentiating between the two. Sigmoidoscopy may be suggestive, but at the same time, histopathology is not very discriminative, very small number of patients. I mean, crypt distortion, they say is a hallmark, but my boss, Professor B.S. Anand, published way back in 86, actually that's the time when we were working there, that shigellosis epidemic, 78,000 cases, 2,200 deaths, and mucal biopsies showed frequent crypt distortion. So that is nothing very absolute about it, but these are all relative features in throughout all this clinical course plus these relative points. Chetan, how do you classify? I mean, can we label it as an acute severe colitis, possibly first episode? Okay. Now, how do you classify severity? What grading you will give?
The most
I have put certain things on the slide for the background, but Chetan will answer that.
even today, 2022, true love and wits classification, clinical classification is very relevant. It is very simple, very clinical. If the stool frequency is 6, no tachycardia, no fever, bleeding in less than 25% of cases, no abdominal tenderness, probably you're looking at a mild ulcerative colitis. Severe ulcerative colitis, more than 10 stools per day, bleeding in almost every stool, tachycardia, fever, abdominal tenderness, that's a severe ulcerative colitis. The moderate ulcerative colitis is in between gray area, which can be interpreted either way.
Actually, it is not moderate category, and this is not clearly defined, but number of studies have been done arbitrarily, keeping that in between criteria. Number of clinical trials they have taken as a moderate stage as well. So I think the criteria of severity should be clear, but do you think each and every parameter carries value? Does it predict something?
See, what happens if the stool frequency is more than 6, that is about 6 to 10 per day, tachycardia, tachypnea, temperature, more number of symptoms, more likely that person is not going to respond to severe ulcerative colitis. He may end up in an urgent colectomy or colectomy at the end of 1 year.
You see, the most important thing when you are managing acute severe colitis is to, can you predict the colectomy rates? And this is classification given in way back in 1950 holds true even today to predicting the colectomy rates. Am I right? There's not
Absolutely.
much difference which has come up in the subsequent. If any of the experts wants to add on, please welcome. Oh, yes. Yes, Partha.
In AIMS, they have shown that they have removed the hemoglobin, and still, if additional criteria, they can predict the this colectomy rates.
Right. But broadly, we fall into this, we agree to that. Huh? Okay, Partha, keep the mic with you. Don't pass it on. do you believe that before starting treatment for a severe ulcerative colitis, a course of antibiotic is essential in Indian settings? I mean, do you think that the antibiotics are precipitating or they can mimic, or what do you want to say? What is your opinion?
Actually,
I know that I will show the letter. It's very confusing, but I want your opinion. What do you follow at your center?
I think a recent study from PGI and has shown that adding a metrogel or other antibiotics have no incremental benefit with any addition of IV steroids.
Actually,
in
that's
acute
very
severe
reason
ulcerative
I kept this
colitis.
question for Usha, but because she's not here, it lands up with you. So you will not, don't, does anybody believe in this thing like that, something like that?
Can I ask a question?
Yes, please introduce yourself.
Myself is Shailendra Jain from Bhopal. Shailendra Jain from Bhopal.
Yes.
Do you believe that, sir, there is in first episode of acute ulcerative colitis, severe ulcerative colitis, will response partially or any sort of response with the antibiotic?
See, that is exactly the question that he was answering. There are some different data from different places, but most of the time, most of people agree to that. That doesn't make. See, mind it, we are talking after 4 weeks of this thing. This is always 3 weeks history, and patient has received some antibiotics here, right? So nobody is saying that you will come, patient will come, in India at least, nobody will come to you at 3 to 4 weeks without receiving antibiotics. By the time, I mean, everybody will receive some 3 weeks diarrhea, everybody will receive multiple courses actually.
I think, sir, the trial that PGI showed that it was a double-blind randomized placebo-controlled trial, and it did not change the outcome, even just giving antibiotics or not giving antibiotics.
Everybody can hear from this mic because this voice doesn't come straight directly to me. I mean, is it audible to everybody? Okay, great.
So at PGI right now, we are not giving routinely any antibiotics. Only if you're suspecting toxic megacolon or any sepsis, that the underlying sepsis, then we only start antibiotics.
So before we come on to the actual treatment, just want to highlight the same thing, that you will check for the opportunistic infections. You will, even though we are not doing too much focus on that. And these CMV stool tests for C. difficile may not be relevant at this stage because it's the first episode and patient is not immune suppressed, patient has not received steroids, but this may be relevant in the other setting. The patient is already on steroids and known case of UC. Viral markers, you get it done for a different reason. That is because in the course of the treatment, if you decide to shift on to biological treatment, you will have the reports prior to that. And a plain X-ray abdomen, Partha, you carry on. I'll just put in an X-ray describing the different findings. I mean, do not ignore a plain X-ray abdomen, please, in this setting before you start the treatment. And the key thing that you like to highlight is to toxic, you already mentioned. Yeah. What diameter do you take as a?
More than 5.5 centimeter.
More than 5.5 centimeter of a toxic megacolon, if corresponds to the clinical.
Another thing I wanted to highlight is also the small bowel diameter. If it is more than 3 centimeter, that it can also predict colectomy with a sensitivity of 60%, right, apart from only colonic diameter.
Right. So it's important to have a simple plain X-ray abdomen there. Dr. Mohan Prasad, you are a leading endoscopist. Will you order colonoscopy in this particular patient?
I will not. I'll do just a flexible sigmoidoscopy because that is important.
Would you like to highlight why only sigmoidoscopy, please, for the benefit of the audience? So
yeah, because you have a sick patient who has got more than 6 to 10 stools and with the tachycardia, anemia, with probable, like a high inflammatory condition. You don't need to do a proper bowel prep.
This type of a picture, yeah. This patient had this sigmoidoscopy picture. So you do not do the colonoscopy because you can cause complications.
Yes, perforation rates are high.
It will not serve you any additional purpose at this stage.
Absolutely, because I just need to know if there are any deep ulceration and how bad is the colon. Just the sigmoidoscopy with just enema prep is enough. You don't prepare.
So I'd like to mention that whenever you do a sigmoidoscopy, please record vascular pattern, bleeding, and superficial or deep ulcer, 3 things, because you can it can help you later on specifying that. Do you think this particular, you can classify barren staging under something, fancy names are there? Does it help you in managing that?
What is the question?
Sigmoidoscopic picture Does it help you in any way changing the treatment?
Yes, of course,
Huh?
because in acute severe ulcerative colitis, if you see a lot of deep ulcers and not the superficial ulcers, then that means the colectomy rates are high and failure rates to steroid therapy is also high. I think I would even use higher dose of drugs, about which I'm sure we'll
That
come
we
to.
can check debate later on. But the other thing is that one you've already said very clearly that please avoid total colonoscopy, do only a sigmoidoscopy.
Absolutely,
And
yes.
the other investigation which we like to highlight, the other investigation to be avoided, barium enema.
Absolutely.
And the third thing, will you take a rectal biopsy or a colonic biopsy?
Rectal biopsy is good
Rectal
enough here.
biopsy should be taken. Why? I mean, why is it so? Just for the benefit of the
No,
audience.
rectal biopsy, I would look at to the proof that it's ulcerative colitis, number one. Number two, if there is any cytomegalovirus, we
That's
can
okay,
spot
but,
it there.
I mean, it's below the peritoneum also, so you have no problems in perforating or something. I mean, you should not be causing a problem. Okay, I'm coming back to you, Dr. Jaina. In this patient at this stage, I'm not saying, but in the patient who has a known ulcerative colitis and has a relapse, obviously we'll test for CMV. Today, just tell the audience that what test do you ask for? What is relevant? Be practical, just tell which all tests you want.
Sir, in acute severe setting, I would like to do tissue histopathological examination with IHC plus minus tissue PCR. That is the
Do
recommended.
you have to do any special stains for in the histopathology, or it's a regular H&D?
Special stains can be done, sir.
Anybody can comment on anybody more knowledgeable about the histopathology can comment on the special stain? Okay. Tissue diagnosis plus the serum diagnosis of PCR, both are important. And simple CMV antibodies, do not be carried away by that. That is not going to be very specific for that.
Tissue PCR, I think.
Huh?
Only tissue PCR, not serum
yeah.
PCR.
Both. Will you do both or will you do one? Who's talking? Can you give mic to Dr. Chobal? His voice is not as loud as his height. Huh? Huh? Okay.
It is also mentioned that you can also go for serum
Tissue,
CMV
we can
PCR.
also do tissue PR.
Tissue
we have
PCR
nothing against
adds
the blood.
even blood also CMV.
Blood
That
also.
I mentioned also about using a
Right.
so-called CMV antigen. I don't know.
Sir, I think tissue PCR is the best way to go, and studies have shown that if the density of the CMV is more than 200 copies per gram, then there is a higher chance of colectomy.
Okay, now yes, Rupa.
That if you are finding a histopathology showing inclusion bodies, we should not start treatment for CMV immediately. I mean, a PCR may not be available because in majority of cases, it is going to be an innocent bystander, and this is for routine practice. The other thing.
So you are trying to say that we should start the treatment without waiting for the tissue PCR report.
Yes, because one is many
The
centers.
point is well made, but the point is valid in a setting, not in setting of this particular patient, but in a setting of the patient who has already been immunosuppressant and gets a flare with a severe colitis. Am I right?
Yes.
Huh?
Yes.
In that setting, definitely, I will agree with you.
Yeah, so I think regarding CMV, there is always some doubts. People stop the steroids and then just switch to this. I think that part also needs to be kept in mind.
So experts have agreed up to this time what is to be done. Now we have a patient of first episode.
Can I add a point here? I mean, just reiterating Rupa's concept. Yes, I think even if there is CMV, we have to start on steroid.
Okay.
And if somebody is responsive to steroid and or a rescue infliximab or whatever, then this CMV is probably a bystander. You don't need to treat. If they don't respond to steroid, then you have to start on treatment, preferably acyclovir.
So we have all agreed on the workup that this particular patient has acute severe colitis, first episode of ulcerative colitis Investigations do not show any complication like toxic megacolon perforation or anything of that sort. So we have to start the treatment. These patients have to be hospitalized. The two things that I like to mention here, any acute severe UC has to be hospitalized. Number two, it has to be a team management. Please involve your surgeon on day one. Don't call them on the day 5 or day 4. So two things to remember, all need to be hospitalized. And number two, it has to be a team effort. The third thing, now we come on to, we all agree, I'm not going to details, that intensive IV regime as initially put forward by Truelove stands true today. But there are certain things which we can all talk about. Dr. Chetan, do you, initially, Truelove talked about tetracycline. If I'm not mistaken, initial paper was on tetracycline. Obviously, today nobody uses that. Which antibiotic, so this is not an antibiotic on context of which we talked about, that before starting the treatment, it is part of the intensive IV regime. Do you use antibiotic? And yes, if yes, which antibiotic?
Normally, I would not like to use antibiotic as a first thing, but if there is significant leukocytosis with a shift to the left, suggestive of superadded infection or maybe translocation of bacterial flora, if I have to use antibiotic, I will use quinolone along with metronidazole.
Quinolone or and metronidazole? What I'd like to know.
I'll add both.
Usually they will add both. The study wise, there's no evidence to that. There have been studies showing quinolone. Even people have used ampicillin studies and so on. And but our national expert tells us that he uses quinolone plus metronidazole. If anybody differs from that, has a different protocol, please correct right now. Yes, Rupa, you seem to be having a different protocol.
No, I just said that in many situations, if it's the first attack of a acute severe colitis, we tend to add antibiotic because you need that little extra time because we don't know whether it's acute self-limiting, particularly low-grade fever. Sometimes even in acute severe colitis, you have.
So I think, see, two different situations. We talked about antibiotics prior to making a diagnosis of ulcerative colitis. But after you have already decided and you are starting intensive IV regime for treating ulcerative colitis, in that context, because you are starting high dose steroids, so will you like to add antibiotic?
No, then not.
Yes, Jyoti.
Yes, I think in acute severe ulcerative colitis who is already admitted, if we are giving IV hydrocortisone is part of our intensive regime.
Yes.
So it is better to start on antibiotics than to wait.
Which antibiotic do you use?
Usually we cover with metronidazole, which is one of the antibiotic. Along with that, either we give ciprofloxacillin or
So
you can.
You agree with what Chetan said?
Yeah.
Your protocol is same.
But usually we give antibiotic. We don't.
Fair
stop
enough.
it.
See, there are certain things which happen out of the, I mean, it's a kind of a policy which, as you know, but there has to be an evidence base for everything. If you look at the evidence base, prophylactic antibiotics have no role in this situation unless they are going in for
Dr.
toxic.
Chobal, the initial protocol by Dr. Truelove had
That was
antibiotics in that protocol and that had evidence. Right now, we do not have evidence
That's
of
what I'm
which
saying.
antibiotic. Which
No, no,
antibiotic?
Agreed.
Yes.
But whatever recent publications on acute severe colitis, they clearly mention that prophylactic antibiotics only in one situation where you have toxic megacolon.
So
We
Rupa,
give
you
it,
can-
that's a different thing. For
you can-
example, acute
Rupa,
necrotic
you-
pancreatitis, everyone gives antibiotics right from the
So
first
Rupa, you
visit.
have a point that you can try to generate
Initially.
evidence for something like that. Which Dr. Chobal said there is no evidence, so you can try to generate evidence for the future. It gives you a question for thought, school for thought. Okay. Dr. Jaina, how will you give the nutrition? Dr. Truelove, when he talked about TPN. Do you give TPN or you give nothing or you give enteral or what?
Sir, initial data, they used to say you have to keep the patient NPO, but rather later we found that had no evidence-based evidence regarding that NPO thing.
If you can give quick answers so that we have to
Sir,
cover a
the
long
recent
distance.
AIMS trial
And
showed
some
that-
of the panelists have to catch flight.
Recent AIMS trial showed that exclusive enteral nutrition for 7 days is very beneficial in.
So you will be in favor of enteral nutrition. Any other experts on the dais has a different opinion? Otherwise, we'll take a call from the audience. No, everybody agrees that you say TPN increases the risk of sepsis, so we should avoid that. Enteral nutrition, unless patient has ileus, actually if patient has got ileus, toxic microbiome, patient will go for surgery. You will not wait for that. So enteral nutrition should be encouraged as much as patient can tolerate. Am I right? Okay. Low molecular weight heparin, what is the protocol at your center, Partha?
All patients with acute severe ulcerative colitis has to be given prophylaxis with low
I think,
molecular weight.
okay, the consensus is that in spite of the fact that the patient is having bleeding, there is a severe colitis, that is not a contraindication for low molecular weight heparin.
I think that's the strongest message.
It's recommended. Actually, the current recommendation, if you have to mention, you have to sum up in one sentence, any patient of UC requiring hospitalization should be a candidate for a low molecular weight heparin.
Also this thrombotic risk persists up to 1 month, sir.
Right.
So
And yes, VG, there has been a lot of noise to combine with the topical therapy of steroids. We are giving parenteral steroids. I'm not right. What is your policy? Do you believe in it and do you give it, or does it help or no?
See, this acute severe UC is totally a different ball game altogether. And I don't think any topical therapy is
So
going to help.
initial regime had mentioned about the topical therapy, but there is no strong evidence in favor of that. And we are always worried that if it is a severe colitis, somebody during providing the topical therapy may cause trauma. Am I right? Everybody agrees there?
Agreed.
Okay, Rupa says they agree, so I have no authority to talk beyond that. Okay. Now, so let's look at this. So we have talked about what investigations we are sending. We have talked about steroids, antibiotics. I have written there Cipro, metronidazole, 5-ASA, so you can stop at this stage. Nutrition, if a patient has been on ASA, you may continue. Rectal enemas plus minus, we don't give it. Prophylactic heparin and nutrition we have talked about. Okay. And these markers we have talked about that they will be going. Now, of course, you should withdraw the anticholinergics, antidiarrheal agents, NSAIDs, and opioid drugs, which risk precipitating colonic dilatation. And if the hemoglobin is low, like in this patient, you should try to keep it around 10 gram by blood transfusion. And coming back to you, Dr. Jaina, how will you monitor once your patient started your intensive IV regime? What do you instruct your resident? What all they should monitor on daily basis? What are the things which should alarm you to change the treatment, or what are the things which, how do you monitor that?
Every patient admitted.
One by one, I have put certain things here. Physical examination, of course, I will mention that is basically to look for any rebound tenderness, so that Dr. G.V. Rao needs to be called at a SOS basis because you have already called him on the day one for as a team effort. But then recording of vital signs, which nurses will do, but you should put a special testing for 4 hours. And what about the stool chart? Please tell the young gastroenterologist that what sort of a stool chart should be maintained.
So the bloody stool frequency is important for day to day for over 24
So you
hours.
talk about number one, number of stools in the stool chart. Number two, consistency.
And the blood.
And number three, the blood. Quantifying 1 plus, 2 plus, 3 plus. Right? This is what they used to teach us when we were at PGI. I hope they're continuing with the same this thing. This must be kept at the bedside. Jyoti, am I right? This is what we are taught in PGI. Huh? Okay. And then measurement of what parameters you will order every day.
A X-ray has to be done daily basis to monitor the transverse colon diameter, especially the dilatation and the lack of ostration is important to document. Electrolytes are important, potassium and especially magnesium, because they can go into colonic dilatation. And heart rate, HB, hemoglobin monitoring, and the two most important is sir, CRP, that is to see for the rest.
That's what I wanted to. What CRP levels are important?
Sir, if it is stool frequency still more than 8, irrespective of CRP, if it is 3 to 8, more than 45 is the cutoff.
I'll come to that later also. And will you like to get a plain X-ray every day?
Yes, sir. At our setup, we are doing.
We'll advise every day, but you can also base it on your clinical examination that the moment you feel patient is going into toxic megacolon or anything, patient is worsening, then you can go. So basically stool chart, CRP, X-ray abdomen are three most important in addition to your physical examination and vitals. Am I right? And then coming on to the second day. Second day, of course, not much. Dr. Mohan Prasad, how will you take a call when the intensive treatment is failed, or is it working or not working? What is
So-
the ideal time when you take a call on that?
I think
Initially, duration of, I mean, just to recapitulate, initial regime was 5 days regime. Am I right?
yeah.
Okay.
Now I think we'll have to prepone that, and the magical numbers are day one and day 4. So if after 3 days of methylprednisolone therapy, if the patient on day 4, I'll assess if he's not responding, definitely I'll have a look at a rescue therapy for this patient.
See, the beauty of this regime
but
is
what
that
about the
there are clear parameters to decide when to do what, when it is successful, when it is failed, when do you shift therapy, and so on. So here, initially it was 5 days, like a CRP more than 45, stool frequency 3 to 8 per day at day 3, almost 85% colectomy rate in this group of patients. And if, so you have a different categories, complete responders, incomplete responders. The definitions are defined, this beautiful paper in 96 in Gut. And then if you look at the overall data over since last 50 years, that response of acute severe UC to IV steroids percentages have not changed. And then it is also the impact of preoperative, that on which particular day you take a decision of colectomy, it matters. If you look at this, the 3 days of regime, now post-operative mortality is the white and the black dot is the morbidity. And if you look at it, the later you take a decision, these figures start going up. So it's very important to take decisions at the right time. So the messages from the conventional therapy is that you start making decisions after day 3, as Dr. VG said. It has colectomy has saved lives, and the rate of colectomy has not changed much for 30 years. And other options are there. We talk about that, which we talk about rescue therapy. And quite often there is something in between that you continue, keep trying the conventional therapy, and which happens quite often because of number of reasons. So if you reach the day 4 to 7, if a patient is not responding, you have already involved your surgeon, you have called your stoma therapist, you have explained to the family, you have mentally start preparing them, and then you take a call what is to be done. So it's this algorithm gives you a clear answers on the question that Dr. VG Mohan Prasad has just answered, that after giving intensive regime, assess response at 3rd day. Complete responders, you are going to oral steroids and add ASA subsequently. Incomplete responders or non-responders, you are talking about colectomy or a medical rescue therapy, or the newer treatments which we have since we had this particular thing. So there are criteria, I'm not going into that, which are less likely to fail or more likely to fail. I'm not going into that. So that's where we are here, that IV steroid refractory. I have put the 3 options. The 4th option I will put as a tacrolimus, and 5th option now, which has been talked about by Uday Ghoshal, which is in the periphery and to which Dr. VG strongly objected, was a newer molecule of tofacitinib. But then let's focus back.
I did not object.
So when you reach this situation, you have, everybody's troubles. Patient is worried that he may require surgery and stoma. A lot of surgeons are shaky. I'm not talking about GV, any surgeon present in the audience, I'm not talking about them. I'm talking about the surgeon which are not present in the house. So please don't take offense. Emergency surgery complication rate is higher than elective surgery. Infliximab, patient is shaky, affordability, everything matters. And quite often physicians are shaky who do not have experience with infliximab. Cyclosporin, physician is shaky because the preference and lack of education on cyclosporin is there. So but it has to be a joint decision. I said multi-team, which can inspire confidence, which can have a knowledge of everybody pulled together and take a call. But mind it, young woman who has not completed her family should not be taken up for surgery. We should avoid surgery because it affects the fertility rates. Am I right? Okay. Okay.
But Ajay, the
Yes.
response to treatment is not there as a life-saving measure.
Hmm.
We need to, because we're not trying to save the colon, we have to save the life.
Right.
When it becomes a dire emergency,
No, we
I'm
were
sure
talking about the
GB will
future.
agree.
No, we were talking about the future life of the mother. Huh? Okay.
Staged approach surgery, they have lesser chance of infertility. Staged approach, like 3-stage approach,
Yes.
that has lesser risk of this low fertility and all.
So I know GB is your boss. You have to please him. Okay.
I think
Yes.
we should ask Dr. GV for his comments. Because I mean, I'm just talking in between. We actually, about a year ago, Dr. GV would be knowing, we had a post-delivery. Within 2 weeks, patient developed the first attack of acute severe colitis. Yes, post-delivery 2 weeks, the small baby at home. We tried everything on earth. And then we had to call Dr. GV. And that time, the patient's nutritional status was not up to the mark. In just 48 hours, we gave some nutrition. And just 2 days back, she came with a small baby. That subtotal colectomy was done on an emergency. Patient survived and is now for completion.
I am very clear in my day-to-day practice. Patient not educated. Affordability is a plus minus because in private sector, even surgeon is expensive. So that's a different thing. Otherwise, affordability does matter, used to matter to us in a patient coming from a remote area who is not able to reach the hospital on a regular basis. I will not even suggest the rescue therapies other than colectomy to them. I mean, that's my, there are certain criteria that we have to see practicability, that when you have a choice between the different options. And all of us are no practicing physicians. When you take a call, we all take these things into consideration.
I think the patient also
and
is
patient
important.
psychology. Patient
Some
psychology.
patients
You see,
just
the
don't want
class that I
surgery.
have told you, they are the ones who will blindly follow you. And the other than that, it will be dictated by the patient's choice, because they will consult Google and come back, and they will consult 10 other doctors and come back to you.
Surgery is the last option in all the situations. As far as patients are concerned, surgery is the last
yes,
option.
yes. GV, you want to say something? Add something? Okay. So, Partha, coming to you. Now you have a choice of a rescue therapy. Do you have any specific choice of the two? Cyclosporin, infliximab. What is the policy at your center, and what is the knowledge about that?
In our center, actually, we have experience more with infliximab rather than cyclosporin, but cyclosporin can be a useful option in low resource settings, and very important. And I think the low dose is 2 milligram per kg can have lesser side effects.
Cyclosporin, see, is a cheaper medicine. But at the same time, I mean, if you look at the data, I don't want to go into too much of literature. I have the data here. It's not much difference when you look at the response between the two groups. But when you look at the long-term perspective, correct me if I'm wrong, I can be wrong here, that cyclosporin group, once they come back to the remission, even then their colectomy rate does not change after that. In the long term, over a year or 2 years, something like that. What is your take on that? I mean, that's a...
So the whatever the randomized control trials have been shown that the response rate are similar, and long-term colectomy rates are also not different between the two, but the cost is significantly less with cyclosporin.
So only thing is that in a patients who have a low cholesterol and low serum magnesium.
And also, sir, who the patients who have received intolerant to thiopurines, they should not be subjected to cyclosporin, I think, because later on maintenance has to be done with thiopurines.
Yes. Anybody in the audience, any choice between the two? Okay. These are trials which are showing the similar response rate between the two. I'm not going to the, this is the conclusion of that trial, that cyclosporin was not more effective than infliximab with acute severe ulcerative colitis refractory to intravenous steroid. So more or less comparable data in this particular trial. And Dr. Ajit Sood Center, there's an Indian data on that. It also shows the more or less the same thing. So looking at these two, so like if you decide to give cyclosporin, you assess response at day 4 to 7. If you have adequate response, you add AZA or shift to oral. If there is an inadequate response, then again you go for colectomy. And if you have an adequate response with infliximab, then you again add AZA and give infliximab at 2 and 6 weeks. Any differences in this algorithm? Yes, VG. I don't know why you always disagree with me.
Ajay, here probably I would add, see, people have shown that because there's so much of TNF alpha, it just binds with the infliximab, and then that way it's lost. Number two, there's a lot of fecal loss of inflixi because of the severe inflammation. So, and then there could be antibodies. All these can reduce the efficacy. So people have shown a high dose of infliximab. Instead of 5 milligram, you can use a 10 milligram dose, or use 3 doses within 3 weeks. That's within 20 days.
So this is a very
accelerated therapy, yeah.
interesting concept. That is that Sarah just told, that the concept of sponge, that the anti-TNFs are more, so it is sucked out like a sponge. And then shark, that the reticular endothelial system just keeps eating those anti-TNFs, and also the sieve, that is the gut, there is gut loss is more. So this concept of sponge, shark, and sieve.
Good.
And sieve. Yeah.
So you see what that, yes, Dr. Chaubal.
See, we have been discussing all these things. We have discussed about Travis score also, the Oxford course, that scoring which is there that you have to see on the third day and all these things. This is all for the initial treatment. Subsequently, when you start rescue therapy like cyclosporin, all these things, do we have any scoring to suggest, just like what we have Travis score initially? Once you put this patient, when do you call the patient is not adequately responding, should go for a colectomy to decide? Like here we know that third day not responding, send for colectomy, rescue therapy. But when you start rescue therapy, when would you say that, no, yes, this is the time that he should go for colectomy?
Studies have actually, sir, tried to, before starting the infliximab also, depending on the patient albumin levels and inflammatory burden, we can actually optimize the dose. Like we can use a higher dose and in a higher frequency, depending on the drug.
We are coming to the more or less end of this discussion.
So last
Before
one.
we finish that, yes, Dr. Jaina, you
Sir,
want
one
to-
last point I'd like to add. In cyclosporin, very important is to give prophylaxis for pneumocystis for 3 months. When you are giving azoran as maintenance, you are tapering of the steroids. Along with triple immunosuppression, it's better to provide prophylaxis. We usually give separate
Good.
prophylaxis.
Thanks for adding that to the list. And
Ajay,
status of
for a take-home message, you will have to tell us when to say enough is enough, we'll go for surgery.
I think that's we have already given that. No?
We have finished. Okay.
No, we have already
7
shown
days,
that. We
day
have already
7.
shown that.
Okay.
I think the same. You commented on that slide. Huh? Huh. Okay. So last question I like to ask, because we have been discussing about it since morning. The status of new drug like tufastinib in, I'm sorry for the spelling mistake, in severe acute colitis as a rescue therapy. And as Rupa had put it, first rescue therapy. She has used this word. I think this has been discussed beforehand, and we know that it is still not approved for that. All of us have anecdotal experiences with this thing. So we need to be watchful for the future that this may be evolving as a newer option for us in treating these patients.
Sir, we have
yes,
published
Dr.
a-
Jaina, you have published
a
some
case series.
something from that from PGI. Can you elaborate the audience about that?
We gave tofacitinib as rather a second line rescue because patient was not opting for surgery as he had failed the 4 patients we have given. 3 in 2 patients their infliximab failure and third patient was cyclosporin failure. Almost out of 4 we could salvage 3.
And I can add my one patient because patient did not was ready for the surgery or for infliximab. There's only one patient that I've used in exactly the same category, and it has shown a response. The advantages of tofacitinib, what we found of a cost factor, oral drug, and relatively quicker onset of action as compared to the other molecules. So if the side effects permit us, and and if further evidence appears, we are not recommending at this stage, but it is a good molecule to look at, to be on the watchful and we observe that. Still, we cannot recommend this in severe acute colitis because it is not a approved indication. We need more evidence. GV has gone, but his question is here. Okay, anybody can answer that. What surgery do you advise for emergency? Partha, what do you do? What GV does at your center?
So first a diversion ileostomy and first a diversion ileostomy.
One step, two, GV is there. GV, question to you. What surgery do you advise for emergency, during emergency?
Yeah, actually, basically, it is going to be for any of these acute severe ulcerative colitis, it is going to be subtotal colectomy, leaving the rectum and part of the sigmoid colon. You're not doing any pelvic dissection during acute severe colitis.
Is it okay? My slide shows
Absolutely.
subtotal colectomy with ileostomy.
Absolutely.
Plus minus closed rectal stump or mucous fistula.
Absolutely.
It sums up. Oh, thank you for agreeing. Huh? We physicians are always scared and respectful, the surgeons. You know, at bad times, they are the one who will help you, will bail you out from the difficult situations. So, well, friends, we conclude by saying that objective for criteria for defining acute severe colitis are there, and number of criteria is related to outcomes, so please count them. And objective criteria for evaluating response to steroids are also there, and CRP on more than 45 on day 3 indicates poor response. Act on day 3 criteria, and cyclosporin if colectomy planning, cyclosporin if colectomy likely and gets out of the circulation rapidly, and infliximab if less severe or patients already on AZA, and consider with care sequential use of both of these agents. At the same time, please, at this stage, start thinking inside, is it the best place for the patient to take care, or you need the help of your colleagues somewhere else? Because this is a very critical patient. These are high morbidity, high mortality. So there is no harm in taking everybody into confidence and also assessing or revisiting your facilities. If experts agree, I must say that it was a wonderful interacting with you all, getting clear messages for everybody. And thank you very much to give me this opportunity to make it such an interesting, I'm just saying that I hope it's very interesting for everybody.